This podcast does not provide medical advice. Please listen to the complete disclosure at the end of the recording.
Hello to everyone, and welcome to Everyone Dies, the podcast. I'm Marianne Matzo.
And I'm not, because I'm Charlie Navarrete.
So please relax, get yourself something good to eat and drink. Anything that makes you happy. Makes me happy. What?
Anything.
Anything. If it makes you happy, it makes me happy. And thank you for spending the next hour with Charlie and me. In the first half, we have our recipe of the week because...
Yes, because...
What would our show be without a recipe of the week? In the second half, I'm going to start a series on talking about the process of dying. Like what goes on. And in our third half, Charlie is flashing us with inspiration.
Yeah, I got off the last episode. Oh, yes, yes, with inspiration. Yeah.
So, Charles, what are you doing for the first half this week?
Well, there are a lot of things people hope to accomplish in their lives. Having successful careers, raising a loving family, making a ton of money. Yours truly would love people to go back to the old days when a martini was stirred, not shaken, so that, in the words of writer Somerset Maugham, the molecules lie sensuously on top of one another. These are among the most common goals, cocktails notwithstanding. All fine and good, but what about food? At Everyone Dies, we would like to remind you of something that is really important, eating. And since we don't want you to go through life without eating as best you can, we have put together 5 things you have to eat before you die, most of which you can make in your own kitchen. But really, what's the point of that when you can just order in?
Well, you're in New York. You can order in.
Well, yeah, that's true.
Not everybody can do that.
No, they can't. I just take it for granted now.
You do?
I didn't grow up that way in the suburbs of Detroit.
No, we didn't.
No, we didn't. Yeah, it's funny. So, with that, can we have a drum roll, please?
Oh, wait, I have my bell.
Oh. Fine, I'll take it. Number 5. Strawberries picked fresh from the field for all your frozen strawberry margarita needs. Ladies and gentlemen, make sure they were picked by union workers. They taste like you died and went to heaven. No supermarket strawberry comes even close to tasting like these bad boys.
Oh, man. Have you ever had that, Charlie?
Frozen strawberry margarita with fresh strawberries?
No. Go strawberry picking and just eat until your face turns red.
Why wouldn't I just go to the local bodega and pick up?
Because they're not the same.
Yes, it's the local bodega, and I don't have to get into a car, drive miles on end, get stuck in traffic, bend over, hurt my back, and get dirt under my fingernails. You're right; it's not the same thing.
It's not the same thing because the strawberries, they're in the fields, strawberry fields forever, and they're nice and warm from the sun, and they just pop in your mouth. Oh,
actually, I have.
Heaven.
And you are absolutely right. I've been strawberry picking, blueberry picking. In the fall, we would always go. Actually, just hop in the car and go apple picking.
Yeah, that's a northern thing. Go apple picking.
Right? Yeah.
They don't have apple trees. Well, they don't have apple trees down there. I guess it gets too hot for the poor little apples, but. Up north, man, that was a major thing. And then get the apple cider and the homemade donuts that are hot out of the grease.
Oh, those. I forgot about those. Yeah. Right. Yes.
Yeah. But none of that's on our list. So next.
4. Freshly made whipped cream. And other delights. Meow. Whipped cream, when made with fresh eggs, can make the worst. Whipped cream made with fresh eggs.
You don't make whipped cream out of eggs.
No?
God, you're such a city boy.
Did I write down the wrong things?
Yeah, I think so. I think so.
Okay, folks, in the dairy section of the refrigerator, Cool Whip. And
I really love Cool Whip, actually.
So yeah, I do too. With pumpkin pie, and I don't know why. Something about the taste of Cool Whip. I agree.
And we didn't have that when we were kids. We had to suffer with real whipped cream.
Didn't it come out in the 70s or not until the 80s?
Yeah, but when we were kids, we didn't have it.
Oh yeah, kids get. Yeah, you're right. Yeah.
Yeah, I can remember my mom putting the whipped cream bowl in the freezer to get it really cold, and the beaters to get it really cold, and then make the whipped cream.
Right.
And Cool Whip came out. I was like, man, I really prefer this. Probably because it has so much sugar in it.
How did I come up with eggs?
I have no freaking idea. It's cream whipped, as the name implies.
Well, I don't know. Maybe eggs come over and then they add a little something to it. How do I know?
Obviously. Well, I'm not gonna
okay. Well, that's cleared up again. Let's move on to number 3, shall we?
Oh, and we have 5 of these. This is going to take all day because we cannot stay on topic. So
number 3, pimento cheese.
Do you like? I love pimento cheese.
Oh dear, that explains a few things. Known as the caviar of the South. It wouldn't be the caviar of the North where we have real caviar. This spread is made. Ooh, what a snob! This spread is made with sharp cheddar cheese or processed cheese. Marianne, processed cheese, Marianne.
Velveeta,
No.
I never knew what real cheddar cheese was until I was an adult. I thought Velveeta was cheese, and that's what it. I never knew there was anything else. Oh my God.
Oh, my heart's breaking. All right, so the sharp cheddar cheese or processed cheese, no judgment. Yeah. Mayonnaise and pimentos. It might not sound like much, say that again, but possibly the greatest thing the South has given us since waffles and fried chicken. Marianne, have you had the traditional waffles and fried chicken?
Of course.
Heck yeah, that's that.
But the one thing I won't eat is like, what do they call it? Chicken fried steak. That is enough to gag a maggot, in my humble opinion.
I've tried it a couple times, and it didn't do anything. It's like, if I want this, I'll go to the Colonel's, or better still, Popeyes.
Yeah, Popeyes is way better.
Oh, and yes, this pimento cheese thingamajiggy, gizmo invention. This is our recipe this is one of our recipes of the week.
So you can thank us later.
Yes. Now, I added a couple of extra things here. Actually, this is part of the 5, but this is part of my contribution. Chinese food. Yes. So, for my recipe, go to the phone. Or, use the internet. Find a Chinese restaurant closest to you, then order. And as a bonus, I have additional recipes for pizza and Mexican food. Okay, it's pretty much the same recipe, but you'll have to look at other ingredients. And number 1, the Dagwood sandwich. We don't know exactly what goes into it, but the cartoon strip shows large amounts of various
everything.
Cold cuts, exactly. Cold cuts, cheeses. And as a safety tip, make sure that those cheese slices are sliced and, not put a hunk of cheddar or Velveeta. Slice that bad boy. Lettuce, tomatoes, all separated by usually a couple of extra slices of bread with an olive mounted on the top. This mounting is becoming a theme here. And if you just...
For you.
Yeah, there we are. As if you just suddenly scaled Mount Kilimanjaro, or what's left of the snowcap. Feel free to add your favorite condiments. For all this fun stuff, go to our webpage. You'll find a link to the recipes and additional resources for this program. We hope you will follow us on Facebook and Instagram, and remember to rate and review this podcast. As a nonprofit, we are dependent on the kindness of strangers and always appreciate your donations. Please go to our webpage to donate in support of our work. www.everyonedies.org. That's www.every1dies.org. Marianne?
So for our second half, we're going to talk about the period around the dying process, the last phase of living. And as Ecclesiastes said, to everything there is a season, a time for every purpose under heaven, a time to be born and a time to die, a time to weep and a time to laugh, a time to mourn and a time to dance. The last hours of life are conceptualized as the peri-death period. And we wrote about this, we were the first to write about this back in 2000 in our textbook, Palliative Care Nursing, that's been published with Deb Sherman. And I don't know, what is it, in the 5th or 6th edition now. But the peri-death period is, think of it like the perinatal period. There's what goes on, before a baby is born, what goes on during the birth of a child, and then what goes on after that child is born. And that's the same is true. You can conceptualize death in that same way. So we're going to talk specifically about the symptoms and experiences right before death occurs. And in future podcasts, we're going to talk about the actual death. And then in other podcasts, we're going to talk about the care of the body after death. And good care of patients and families during this peri-death period requires intensive holistic care. So in the first phase, peri-death phase, are symptoms and experiences that occur before death. So the peri-death period begins with a preparation phase, a hallmark of which is the realization or acknowledgement that death is inevitable and it's near. Even if it's been considered before this as the dying person and their family members, this is the period when it's actually happening. And so they're preparing for the actual death. Now, the person who's dying may feel uncomfortable with physical symptoms like pain or difficulty breathing or fatigue, or emotional issues like depression or dependency, that they might feel ready for the end. They're ready for life to end. And I've seen this many, many times. It's like you do get to a point where it's like, all right, enough is enough. I've done what I needed to do. I've had so many patients say, I've done what I needed to do. I've said what I needed to say, okay, let's be done. It's like, well, your body now has to shut down. It's not like, okay, you're done. So, we pull a switch. It's not like that. So the readiness to be ready to die can conflict with fear of the unknown and concern for how the family is going to cope after the death. Family members are confronted with their role in the dying process, the prospect of losing their loved one. And conflicts can arise from these and other issues. And as you know, I've worked as a hospice nurse for about 6 years, and trust me, there is nothing like the end of life to bring out the best and the worst in people, and I've seen an awful lot.
I bet,
The patient's role within the family is going to change as the family learns how to provide care, administer medications, all of the things that go with the end-of-life period if they're receiving home hospice. So any, all, or none of the following symptoms can occur during the final stages of the dying process. The focus I'm going to talk about here is on the physiological changes, the changes within the body that occur as death is imminent, and what we would consider to be best practice now. So the body itself is going to focus on keeping the heart beating so that it can keep the brain flush with blood. And that is its agenda. Like if the body could talk, it would say, I'm here for one reason, move the blood around, keep blood going to the brain. I don't care that there's food that needs to be digested. I don't care that there's medicines that need to get moved through the system. I don't care. I'm here to keep the heart moving because we need that to be alive, and the brain. And so I want you to remember that the body is protecting these functions. And I want you to think about that as you're going through the end of life with someone, is that the body has an agenda, and it might not be the agenda you have as you're trying to get the person to eat, for example. That's your agenda, and that the body's like, I don't want any of this stuff, but we'll get to food at another time. So the first symptom that I want to talk about, and we're gonna break this up over a bunch of series of podcasts because it's a lot. I mean, we got a lot of systems in our bodies, and a lot can be going on. So today, first one I want to talk about is pain. So as the body begins to shut down and die, the need for pain medication can change. It can actually decrease. It can need less pain medicine as the body is shutting down. Now, drugs most often used to manage pain at the end of life are something called MS-Contin, morphine sulfate, or what you might hear people calling MSIR, morphine sulfate instant release, OxyContin, oxycodone. So those are drugs that you typically are going to see. Now, the liver, what the liver does is it makes the drugs more soluble, softens them up, if you will, in a sense, and easily excreted, easily put out through the kidney and, through the urine. So that's how that works. So these drugs, those ones that I just named, these drugs and their active metabolites, so every time they break down, these drugs kind of change into a different version of themselves. Let's think about it that way. But each of those different versions of themselves are going to cause a pharmacological effect that then the kidneys have to clear out. So it's not just, the first time that you've taken the medicine and the kidneys clear all of it out and there's nothing else left for it to do. There's these things called metabolites as that drug breaks down that the liver and kidney still have to deal with. The stuff that's left behind, it's still going to be metabolized. So as the body is dying, the liver and kidneys aren't really working that well because what's the body doing? Taking care of the heart and the brain. So as the body's dying, the liver and kidneys are not really all that concerned about the drugs. And so those drugs are going to be cleared from the system very slowly. This results in an increase in those blood opioid concentrations. Like instead of it being, wham, bam, moving out, they're kind of just sitting there and they're going through the system. But as they're going through the system, they are doing what they were there to do. Like just because the body is shutting down doesn't mean they're not going to, have a pain effect or a sleepiness effect. They're still going to do what they're there to do. So this results in increase in blood opioid concentrations, which results in increased drowsiness, sometimes mild confusion. So the priority should be to keep the patient pain-free and comfortable, but with the understanding that the dosage to accomplish this could be considerably less than what it previously had been for effective pain management. So I want you guys to know that so that, I don't read posts on Facebook that says, oh my God, the hospice nurse came in and cut his pain medicine in half, and why are they taking pain medicine away from my dying parent? I want you to know why this occurs because, as I explained, there's more in there than what would normally have been. Everyone should understand the importance and value of pain management during the dying process. The patient may seek pain relief, or they may view pain as a way to atone for sins and refuse to be medicated. I've had patients who's like, I'm not going to take any pain medicine. I'm going to tough this through. Certain religions believe that, you atone here so you don't atone there.
Right.
Well, okay. And what I say to patients in that situation is, okay, but if you change your mind, please let me know. Nobody's going to give you an award wherever it is you're going for having been in pain. So if you want pain medicine, I'll give it to you. If you don't, I'm not going to force it to you. So some healthcare professionals who are not, really in tune with the dying process might worry that they're using too high of a dose of morphine that's going to result in hastening or causing the death of their patients. Family members can fear being the person who's going to give the last dose of morphine before the patient dies. I've had so many patients, families, who when I've gone out to the house, to pronounce somebody who's died, the caretaker will say, could you just come to the kitchen for a minute? And I know what the conversation's going to be when they say that. They'll say, okay, now, before he died, here, let me show you on this. This is what I gave him. It's like, yep, that's exactly right. Well, I didn't kill him, did I?
Wow.
No,
Okay.
you didn't kill him. The cancer killed him. The COPD killed him. Whatever disease they had killed them.
Right.
But because we're mortal, there's always going to be a last dose. There's always going to be. And the reason for that is because we're all going to die. And so there is no cause and effect between that last dose and the fact that they died afterwards. You could say, well, they finally got comfortable and they were able to just rest and relax and take that last breath. Or it could, have absolutely nothing to do with anything. But you don't want to keep pain medications away from somebody because you're afraid of that. Not adequately medicating for pain, though, can interfere with the memories that the family are going to carry with them for the rest of their life. They will remember the death of their loved one as a time of agony and pain, rather than a time that could have been used for conversation, have had more a meaningful or memorable time together. You don't want to go through life thinking, oh my God, I could just see, my dad or my mom just, I could tell they were so uncomfortable, but I was so afraid to give their medicine. And oh my God, and you don't get a do-over in that death period.
Right.
Once the death happens, there's no do-over. So let us educate you about what's going on so that you can be sure that they're comfortable and not have to carry, or anybody in your family, bad images around with you for the rest of your life. At this time, comfort and alleviation of pain is a priority. If the pain medicine isn't working, make sure you call your hospice nurse or whoever's managing the care before it becomes so intense that it is causing unbelievable suffering. It's a lot easier to get pain in control ahead of time than to wait till it's out of control and try to catch up and try to get enough medicine in there so that the person will feel better. Dosages can be adjusted. Pain relief is always an attainable goal. Now, let me give you the caveat with that, though. Some people, I'll say, okay, so we're going to manage your pain. Now, if in order to manage your pain, you have to be a little bit asleep or sleepy, is that okay with you? Many patients will say to me, I've said what I needed to say, I've done what I needed to do, I'll take sleepy rather than being in pain. Other people will say, no, I can put up with a little bit of pain, I'd rather be awake. Okay. Either way, we can do that. And if you change your mind about either one of those, we can change the dosage of medicine. I'm not talking about euthanasia. I'm not talking about end of life. I'm talking about managing pain.
Right.
And, if you have an adequate amount of pain medicine, you can get pretty sleepy. So given that pain medications cause constipation because it kind of slows everything down, you have to be vigilant in checking for constipation. So you think, well, they're not eating, they're not drinking, they can't get constipated. Yes, they can. So be sure to, continue to use the bowel regimes to prevent or alleviate any discomfort, any abdominal discomfort. Other non-pharmacological things that you can do to help with pain are a calm environment. So if you and your sister decide that you need to have a fight right now, go out in the backyard, because that's not going to create a calm environment in your mom's room. Soothing music. Now, some people don't want soothing music. Some people don't want to hear the angels singing. They want to hear country western or Zydeco or whatever. So whatever is soothing to you is what should be played. Aromatherapy helps. Lavender is particularly calming. But again, if the person hates the smell of lavender, don't do that. Human touch is very calming. So feel free, if they're in a hospital bed, put down the side rails, crawl into bed with them, and lay with them. It's okay. I would encourage it.
Yeah.
The side rails are to keep the person from falling out, not to keep you from getting in. So go ahead, get close. If you use Reiki or therapeutic touch, that's very helpful. That can relieve stress, be a source of comfort or support, and can overcome the fear of abandonment. It can be a very soothing and special time to be with somebody as they're going through this process. So that's what I wanted to say about pain. So we're going to do one other topic this week, and that's weakness, fatigue, and skin changes. And I know it sounds like I've made a big jump, but there's a lot that goes on. So we're going to do weakness, fatigue, and skin changes. Now, fatigue is a primary complaint of patients in the last 4 weeks of life. The tiredness can be a result of the disease. It could be a result of whatever treatment they've been getting for the disease, as well as malnutrition because they're not eating, disruptive sleep patterns for a lot of reasons. Fatigue can interfere with a person's ability to move, to bathe, to go to the bathroom. So while the patient's at a high risk, while the patient's not moving around very much and very tired, they're also at a high risk for pressure ulcers. Now, traditionally, traditionally, with people who are laying in bed, we move them from side to side, we, position them, we do lots of things to keep their skin from breaking down. But remember, right now, we're talking about the peri-death time, and so those rules change. Turning and positioning should be done as frequently as possible, but only as often as comfort permits. So if you go to change the position of your mom or your dad or your husband or wife, whoever, and they moan in pain, leave them alone. Don't, and you're thinking to yourself, oh, well, they've told me all along that I have to worry about, pressure ulcers and this and that. Trust me. At this point, before they're dying, the pressure ulcer is not an issue. You can, if they're in bed and not moving, you can almost count on that happening. And it's not a sign of poor care. There are some people who don't know the stuff that I'm telling you. And if they saw a pressure ulcer, they say, oh my God, you're just a terrible caregiver. No, that's part of the dying process. So you want to turn them as frequently as possible, but only as often as comfort permits. The bony parts, that stick out should be padded and supported if this is comfortable for the patient. If any of these interventions result in increased pain or suffering, they should not be implemented. I know, I'm not usually this emphatic, but I'm so emphatic about this. Don't do it if it's going to hurt them. This may be difficult because it's contrary to what you've been told all along. But when the patient is actively dying, intervention goals should focus on comfort. Any intervention that compromises this goal should be discontinued. So, about 56% of patients who died in an intermediate care facility, like a nursing home, developed pressure or ulcers within the 6 weeks prior to their death. Now, when it's within that period, when people are dying and they get pressure ulcers, they have a name. They're called Kennedy ulcers, not for the president, but for the nurse who wrote about them.
Oh.
Kennedy ulcers, they're described as pear-shaped. They're on the bottom part of your back, or on the bottom part of your butt, your rump. I don't know, whatever you is the right word to call it. So these they are red, yellow, or black. They come on very suddenly, and they're a sign that death is imminent. So the susceptible patient is someone who's spending more and more time in their bed, their condition's getting worse, and they're having what's called multi-system failure, which we'll talk about at another podcast, but it's when everything's not working.
Right, yeah.
And growing weakness along with decreased activity and mobility, poor nutrition and hydration, not being able to control their urine or their stool, and changes in their sensory perception and consciousness. Along with this is something called the 3:30 syndrome. Now, this shows up differently and faster than Kennedy ulcers. It can come on very quickly, sometimes in a matter of hours. And what it looks like just little black spots. It looks like a fleck of dirt or dried bowel movement or something like this, and you can try to wash it away, and then you realize it's not on the skin, it's under the skin.
Oh, okay.
And as the hours progress during the day, so if you find them in the morning when you're washing the person, as the hours progress, this area becomes larger, and in a matter of hours, it can be like the size of a quarter or 50-cent piece, silver dollar, and it looks like someone colored the skin with a black or a purple marker. The usual story is that the patient got up in the morning, skin was examined, they had their bath or whatever. Everything was normal and intact, and there was no discoloration. Then, so this was discovered and written about in a nursing home. So then at 3:30, which is, that change of shift time, the patient's put back to bed, and the skin shows this blackened discoloration. So it was named the 3:30 syndrome. I know it's difficult to believe it actually was not there in the morning and that it's so big 6 to 8 hours later. But it happens, and the life expectancy of the 3:30 syndrome was death within 24 hours.
Wow.
And I do expert reviews for a lawyer for lawsuits, review what goes on and give expert opinions. And there are more and more lawsuits against hospices and people receiving hospice care for decubitus ulcers at the end of life. Oh my God, you didn't take care of Mom. Look at this horrible ulcer.
Wow, okay.
So then they blow up that picture of that ulcer, show it to a jury.
Oh, yeah. Okay.
And people get money. And because a lot of people, lawyers, experts, whatever, they're experts, they would know, but sometimes they can find hired guns that'll say anything for money in terms of doctors or nurses who don't know that this stuff occurs. They'll say, oh my God, this is just horrific care. It's like, no, sister, this is what happens at the end of life. It's not that anybody did anything bad. This is just what happens. You don't sue for that. And so it always makes me sad and upset when I see these lawsuits for something that there is no way the hospice or the nursing home could have prevented, because it's normal. It's part of that end-of-life period. So that's my little rant about that.
So even when that's explained to a jury, a doctor explains it, experts explain it, the jury just doesn't accept it? They don't buy it?
No. I've been in that. I've actually testified at a jury trial once,
Oh,
and
okay.
they had these big blown up pictures, and the grieving family member there, and no, even though it was explained, even though because they always talk to the juries afterwards, it's like, yeah, I understood that. I really liked that expert. They liked that I explained it to them, but they just that
It's all
the
emotion.
the wound looks so awful that it's hard to comprehend that it could get that bad that fast. But it can, and it does.
Yeah.
So, and you can't prevent it. Somebody's not eating, somebody's not drinking, they're not moving. You can't prevent it. Because remember, the body is taking care of its heart and its brain.
Right.
It don't care if you're getting an ulcer on your rump. It don't care. Let it. It says the brain and the heart. I don't care. We got sassy brains and hearts. I
don't know. I'm listening to you, the way you're putting it right now. If you were to speak like that in a courtroom, really, I think, I don't know. I just imagine the jury would like, oh yeah, I get that. Okay, sure, yeah. I don't know. Wow. No, but you're right. It's very emotional. Yeah, and a picture is worth 1,000 words. So
exactly.
Yeah.
Exactly. And if you're not clued into the physiology, it just doesn't make sense. It doesn't make sense. So therefore, somebody did something wrong. So Charlie, got an inspiration flash for us after I've I did what I did.
Cheered us all up. Great. This is what
my
I have
work
to follow.
here is done.
Let me ask something. Psychedelics, like micro, because I've read a couple things. Micro doses of LSD, and again, LSD got got a real bad rap. People abuse it, and just all of that. I understand that. But it seems that there have been like a lot of studies with micro doses of LSD, xylophone. Again, not that it's going to basically just to ease things for people, not to get them high or anything. But if people are dying or are anxious, just having difficulty going through it, that in like micro doses. I think one of the studies was out of Johns Hopkins that it seems to help a lot of people. Just as you were talking about making a transition, do you have any thoughts on that?
Yeah, we published a paper about that a couple of years ago. So if you want, I can post that and send it to you. There are minimal studies. It seems to be helpful for people, especially people who are very anxious or have other kinds of issues that they want to work through. I don't know that you're going to see it in general practice, because sometimes some of those trips can be scary, but there are some data, and I'll share that paper with you if you're interested.
Yeah, absolutely.
Let me make a note.
How about an A flat? Well, there's a note right there.
Yeah, I dropped my bell. Sorry.
All right.
So, Charles, inspire us.
Huh? Oh, yes. One sees great things from the valley, only small things from the peak. I knew that English major degree would come in handy one day. The starring character of English writer and philosopher G.K. Chesterton's first book of short stories, The Innocence of Father Brown, is a priest-turned-detective who combines scientific observation with spirituality. At this moment, Father Brown is explaining to another priest how things can change based on perspective. The quote speaks to the value of humility. Looking down on the world from a lofty height makes things appear small. But when we are down in the valley looking up, we have a much better grasp of what we're seeing. And it just brought other observations to mind for me. For example, why did kamikaze pilots wear helmets? Outside of a dog, a book is a man's best friend. Inside of a dog, it's too hard to read. Don't sweat the petty things, and don't pet the sweaty things. And that's it for this episode. Please stay tuned for the unending escapades of Everyone Dies, and thanks for listening. This is Charlie Navarrete, wasting away again in Margaritaville.
And I'm Marianne Mazzo.
Hey, where's that lost shaker of salt?
And we will see you next week. Remember, every day is a gift.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.